Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, friends and colleagues. I'm Fathiya Al-Awadi, President of Emirates Diabetes Endocrine Society, and it gives me great pleasure today to welcome you all and also our great faculty who we're going to hear from them soon to our Summer School of Diabetes Module number 5. And this Summer School of Diabetes is supported by our great partner, Eli Lilly, who've been supporting the society for many years for many good initiatives and continuing medical education. So we thank them for their support for this meeting and for this series of the summer school. So I'm sure that many of you who attended the previous 4 modules are already aware of the program objective, but I would like to repeat them for those who are a newcomer who are joining us today for the first time. The idea came in order to develop a comprehensive understanding of pathophysiology, diagnosis and classification and management of diabetes, and also to apply the UAE type 2 diabetes guideline, which had been launched in February of this year, 2026, during our annual meeting, EDIC, in order also to learn the pharmacotherapy. As you're all aware, that revolution in the management of the diabetes in the past several years, also to understand the diabetes-related complication, and also to stress on the lifestyle management, and also to utilize the case-based learning to apply evidence backed with decision-making in a complex clinical scenarios. So as I mentioned, today is our 5th series, and can I have the next slide, please? Can I go back? I'm sorry, because this is the, it is, CME accredited program. And as I mentioned, there are 6 modules there. You are required also to scan the QR code at the beginning of this webinar in order to attempt the questionnaire. And at the end of the today's meeting, also you need to take a scan of the QR code in order to secure your CME certification. And next slide, please. So already we had covered in the first module the roadmap of UAE National Type 2 Diabetes Guideline, the 2026 update. In the module 2, we had the understanding of action and breaking inertia and champion early control. And in module 3, we had the weight and clinical improvement from risk to treatment target. And on module 4, we have the oral therapy. And today we are discussing the injectable therapy beyond the fair. And the forthcoming webinar, which is going to cover, or the module 6, will cover diabetes complication from risk to prevention. So your learning journey will be start from the time of the registration and enrollment that you had received through the mass email, which is sent from our database. You will need to complete the pre-learning MCQs for each modules, as we stated at the beginning of this webinar, and also to complete 6 weeks of learning, which means you have to attend the 6th module, and then join the live expert discussion panel. We encourage you also to post your questions and to make it more interactive so that we all benefit from this meeting, and then to complete the post-learning MCQs for each module. And of course, following all of this, you will be, awarded your certification for completion of 6 modules. If you had missed any one of them, we encourage you to go back. It's available on demand at different, channel, which I'm going to, show you shortly. So the next slide now. The webinar is live stream now on our EDS YouTube channel for those who's joining us there. So welcome as well. The webinar will be available on demand on our platform of the EDS YouTube channel. And if you have any question, please, as I mentioned, that we encourage you to ask as much as you can from question. You can type them in the chat box or the Q&A box, and we will try to take as much as we can at the end of all the presentation. Again, I'm repeating, it's a CME accredited, and you will be receiving attendance certificate on completion of the 6th module. And if you face any technical problem, please feel free to contact our technical team by typing in the chat box. So our agenda for today for the injectable therapy, we have a great faculty of our four speakers who I'm going to introduce shortly. And at the end of all the four talks, we're going to take the Q&A session. So let us start, and it gives me a great pleasure to introduce our first speaker, who's well known to all of you, Dr. Tariq Fayyad, who's the Chief of Endocrinology, and he's a consultant physician at Sheikh Khalifa Medical City, Abu Dhabi, and he's going to cover the injectable today more than the last resort. Dr. Tariq, please share your presentation and in a slide mode, please.
Thank you very much indeed, Dr. Fathia, for your kind introduction. And it gives me really a great pleasure to be among colleagues, again, just to share very topical areas. And we have distinguished speakers along faculty who are going to share their in-depth experience. So the title which was given to me was Injectables Today, More Than the Last Resort, i.e., it's not something which we only do it if we have to, something which is really when we run out of other options. So with that regard, let me to start with share with you the learning objectives which I'm going to address this evening. The first objective is injectable therapy as a timely option. So timely option is a key words here, rather than a marker of therapeutic failure. When we fail all other therapies, the last resort will be to throw this therapy to the patient. So I'll make the case for timely therapy. And then identify clinical scenarios in which injectable therapy should be. So the word should be is key here. Should be introduced early. And early is another key word here. And then compare the goals of initiating insulin versus incretin-based therapies. I'll go through that as quick as I can. And maybe this is one of the most important things, counseling patients using benefit-focused language that reduce resistance to treatment intensification and improve adherence and mitigate side effects of therapies. So all these are things which are very important when you talk about these injectable therapies. And this is the outline of my presentation. I'll start by addressing what to use when treating dysglycemia and type 2 diabetes. And then I'll go through the scenarios where we should give the therapy regardless and no matter what. So in patients with cardiovascular disease, no matter what, yes. Reducing the risk of cardiovascular disease in the setting of kidney disease, yes. Nephroprotection in CKD, yes. Treating to control glycemia and reduce vascular disease in patient on dialysis. Now, this is something interesting. The answer is yes. Heart failure with preserved ejection fraction, yes. Sleep apnea, yes. Glycemic management in MASH, yes. And then, because of everything is yes, then what are the challenges that come up along with the word yes and yes and yes for everything? And then, do we need more molecules, and why? Adherence and side effects of therapy. So what to use when treating dysglycemia? Well, the ADA will say, obviously, you treat the glycemia, which is very important part of the management. Don't forget the blood pressure and do it very well. And the 2026 guidelines will say, encourage patient to go to less than 120. So now we are playing at the edge of blood pressure, less than 120. Key number, less than 120. Lipid management, we need to do it very well. And then agents. So this is the theme of what I'm going to discuss for most of my presentation. Agents with cardiovascular, kidney, liver, sleep apnea benefit. So these are the things. So what the 2026 guidelines say? It will say with regard to the first learning objective, which is use the injectable therapy in a timely manner. What the guidelines say? The guidelines will give us guiding principles, two guiding principles. And these are individualize the therapy. And number two, consider benefits of early treatment. So the guideline is very clear in saying early treatment. And then what it says when it comes to choosing a therapy, it gives criteria to what therapy should we choose when we are treating early. Number one, and there are three of them. Number one, more intensive approach have a greater likelihood of achieving glycemic goals. So a treatment which has a robust A1C reduction is more likely to get you to goal. Common sense. Number two, high magnitude of weight loss usually result in larger HbA1c reduction. Yes, so losing weight is very important. And the third one is when you decide about choosing pharmacotherapy for type 2 regimens with both. So it says both now. Both are equal partners or equal requirements. Glucose and weight lowering properties should be considered. So both of them control the glucose and control the weight at the same time. So this implies that the therapy, we need to use therapies which not only have potent HbA1c reduction, but also meaningful and significant weight reduction. And what is that? That's the non-insulin injectable. So that's what they are saying in another language, in different language. So what are the clinical scenarios in which injectables should be introduced early in the disease process? This will take us to the scenarios. So we have the cardiovascular risk reduction, we have the SURPASS CVOT trial, and we have the SUSTAIN 6, one with dual agonist, one with GLP receptor agonist. So what's the evidence there? We have the SURPASS CVOT trial, which used tirzepatide up to 15 milligram, or some of you would recognize it as Mounjaro therapy. It was compared to a therapy which was well established in reducing cardiovascular disease, dulaglutide 1.5 milligram, and dulaglutide reduced cardiovascular disease in patients with and without pre-existing cardiovascular disease. So it makes sense to use to test tirzepatide against a therapy which showed superiority in achieving cardiovascular risk reduction. And indeed, the primary endpoint is for tirzepatide when it comes to cardiovascular protection is no less or not inferior to dulaglutide. And yes, they achieved that. So it's non-inferior to dulaglutide with a p-value of 0.003. And you can see very clearly that there was 8% relative risk reduction in cardiovascular events with tirzepatide, but the p-value for superiority was 0.09. So it is this trial established tirzepatide as an agent that can be used to prevent cardiovascular disease in patients with high-risk patients with diabetes. The other study was a SUSTAIN 6 trial with semaglutide. Again, semaglutide showed superiority, but here its difference, it's over placebo, over standard of care. So they demonstrated 24% relative risk reduction in cardiovascular events. So we have two agents which cover that area, and then reducing cardiovascular events in type 2 diabetes with CKD, and this was a recommendation which came this year, where the ADA recommended that people with type 2 and chronic kidney disease it's recommended to use GLP receptor agonist with demonstrated cardiovascular benefit to reduce the risk of cardiovascular events. So reducing cardiovascular events in patients with CKD, GLP receptor agonist is a recommended therapy. And this was based on the sub-analysis of the FLOW study using semaglutide in patients with chronic kidney disease, where it showed a reduction in cardiovascular death. How about nephroprotection? So we have the nephroprotection properties of these agents. We know for a long time that GLP receptor agonist and dual agonist, they reduce albuminuria, but now we have a study which looked at the GFR, so the harder endpoint, and the FLOW study recruited patients with chronic kidney disease, type 2 diabetes, either patients who have reasonable GFR but heavy proteinuria, or patients who are at the lower category of GFR, 25 to 50, with milder proteinuria, more than 100 milligram per gram, or if you're using millimole per gram, then it's more than 10 millimole. They were given semaglutide 1 milligram or controls, and they found that treatment with semaglutide reduced renal endpoints significantly, 24% reduction in the renal endpoints, including decline of more than 50% in GFR less than 15 with kidney replacement therapy, kidney death, or cardiovascular death. Fair enough. And then they looked at the all-cause mortality. Again, it was reduced. So this was very impressive to achieve in patients who have chronic kidney disease, 3-point MACE, and the GFR again. So we can see the GFR every year. Patients who took the treatment were better off by 1.2 ml per minute per year. So nephroprotection was demonstrated very clearly. How about patients on dialysis and end-stage renal disease? The guidelines are now changed their language, and what the guidelines say in the living document of ADA, it's saying individuals on dialysis can be safely initiated or continued. So those who are already in treatment and now they're on dialysis, or they went to stage 5 kidney disease, GLP-based therapy that is not dependent on kidney clearance to reduce cardiovascular disease and mortality is recommended. So what are the treatments, GLP therapies, which are not dependent on kidney clearance? The ones which are dependent are 2, which we don't use them anyway. These are exenatide and lexisinatide. But the others, they are not dependent on kidney clearance. So we can use all of them. So that makes life easier to remember this point. How about heart failure and injectable therapy and the management of diabetes? Well, the guidelines from, again, the living document recently changed the language, and it says the following. Dual GIP and GLP receptor agonist, tirzepatide, or GLP receptor agonist with demonstrated benefit for reduction of heart failure events and heart failure symptoms, respectively, in adults with type 2 diabetes, obesity, and symptomatic heart failure, HFpEF. So the guidelines recommend either the dual agonist or GLP receptor agonist if you have a patient with type 2 obesity and HFpEF, because it's going to reduce the future events as well as cardiovascular death. What is the evidence for that? The evidence for that came from a study, the STEP HFpEF, diabetes mellitus, and here we can see the Kansas City cardiomyopathy questionnaire, placebo, and improved in quality of life with semaglutide. Equally, the summit, which included 47% patients with type 2 diabetes, again, with tirzepatide, we saw significant reduction in cardiovascular death and worsening of heart failure. So the endpoints are different. So here we're talking about symptoms of heart failure, and here we're talking about cardiovascular death and worsening of heart failure. And tirzepatide resulted in 38% relative risk reduction of this serious complication. So what should we do? So if we have a patient who have HFpEF or moderately reduced ejection fraction, the guidelines, now what it says use obviously SGLT2 inhibitors. You have DAPA and IMPA, both are good for HFpEF. Use non-steroidal mineralocorticoid, finerenone, and use GLP receptor agonist or tirzepatide, dual agonist for these patients. If their ejection fraction is more than 40, let me remind myself and remind you of the importance of measuring NT-proBNP as an important screening test that will pick many of these patients well before they get symptomatic stage B heart failure. If the patient is having HFrEF, then obviously the treatment would be SGLT2 inhibitors, MRA, spironolactone, beta blockers, and ARNI. So there's a difference in the management between the two. And really, we need to be conscious of these. So we, as endocrinologists, as part of the CKM team, the cardio, kidney, metabolic, can sometimes we put our nose and management and manage the heart failure according to the guidelines. Very important for us. We're becoming jack of all trades and master of all trades as well. So sleep apnea, another scenario where we need to give the treatment, and the evidence for that came from the study with tirzepatide, which looked at about 500 patients. Some of them were receiving positive airway pressure therapy and the others not. So 2 trials. You took patients with severe, moderate to severe sleep apnea with obesity there, and they give them tirzepatide, and we can see here that a third are class 1 BMI less than 35, about a third were class 2 obesity, a third were class 3 obesity. All of them has quite significant sleep apnea. And obviously they had metabolic syndrome was common in these patients. So if we look at the hypopnea index, we can see very well that tirzepatide reduced that significantly in group 1 patients who were not taking CPAP, and in group 2 patients who were already on treatment. So significant impact of the treatment. Not only that, but obviously we saw that there was a gratifying weight loss of 20% brought about by tirzepatide in these trials, and this led really to the approval of tirzepatide as an indication to treat sleep apnea. This is the dual agonist, was the only therapy which had a trial in this area. So among patients with moderate severe sleep apnea, tirzepatide reduced hypopnea index, weight, it reduced body weight, hypoxia burden, reduced inflammation, blood pressure, and improved sleep-related patient-reported outcomes. Another scenario where we should give the treatment, and that's metabolic dysfunction associated steatohepatitis. And here, now the FDA would say to get an approval, you need to show demonstration of resolution of MASH or without worsening of fibrosis, or the opposite, improvement in fibrosis without worsening of MASH, or without worsening of inflammation, or both of them. So the first study was the Synergy NASH by tirzepatide. They took patients with MASH and they give them tirzepatide, 10 and 15 milligram was the aiming dose. These patients have stage 2 and 3 stage 3 fibrosis, biopsy confirmed MASH, with and without diabetes. So this study was done in patients with and without diabetes, and they demonstrated very clearly that treatment with tirzepatide reduced inflammation with resolution of MASH without worsening of fibrosis. Again, there was a reduction in fibrosis, but it did not hit the P point. But this is anyway phase 2 trial with small number of patients. So really, the trial was very promising in managing MASH patients. So phase 2 trial, tirzepatide for 52 weeks, result in resolution of MASH without worsening of fibrosis, and larger, longer-term trials was to follow. The other study was by semaglutide in the highest dose, 2.4 milligram. It showed the reduction in fibrosis without worsening of inflammation, and the reduction in inflammation without worsening of fibrosis. So it met its primary and secondary endpoint. And because of this, the guidelines now from the ADA will say in patients with type 2 diabetes and mast cell D and overweight or obesity, consider GLP receptor agonist with demonstrated benefit in MASH, or dual GIP, GLP with potential benefit in MASH for glycemic management as an adjunctive therapy to intervention to reduce weight. And the other recommendation, others with type 2 diabetes and biopsy proven MASH, or if you have liver fibrosis by non-invasive. So non-invasive is FibroScan, with showing F2 or F3, fibrosis stage 2 or stage 3, a very simple test to do, which one need to do it repeatedly in high-risk patients. GLP receptor agonist is preferred for glycemic management due to beneficial effect in MASH. PIO and dual GLP-GIP can be considered for these patients. So that's what the guidelines are saying with regard to MASH. Now, the good news is that we have many things. We have many indications. So we have indications as a monotherapy, because guidelines will say start early with potent therapy and aim at A1C and getting the weight at the same time. So early treatment, foundation treatment, type 2 diabetes. And then if you have patients who have more advanced disease, obviously even with insulin, give the treatment, because it's going to have really about 2% reduction in HbA1c, or even greater with tirzepatide. Cardiovascular risk reduction, another indication for injectables. Sleep apnea, tirzepatide is an indication. MASLD and MASH, chronic kidney disease, obesity per se, with or without the above, mortality benefit, arthritis benefit, mobility benefit, what have you. So the guidelines are saying monotherapy, especially with these conditions, and combination with anything except DPP4 inhibitors. So GLP receptor agonist now, ladies and gentlemen, is not a diabetes medication. It's population health drug. Indications are rapidly expanding. Eligible population for the therapy is rapidly expanding. And so the therapy is moving from the endocrine specialty to population scale chronic therapy. And if you look at the trend, this was the trend of semaglutide. It took what, about 8 years to reach this point. And tirzepatide, since its launch, now over 3 years, it reached the same peak. So tirzepatide is the world's best-selling drug today. So this is just to give you a picture of how fast is the expansion of these products. This really created system challenge and access to medications despite support by guidelines. So we have delayed initiation of therapy because insurers will delay the approval. This will result in loss of glycemic control. It will result in weight regain, interruption of therapy, maybe with more fat mass, with interrupting therapy, impact on kidney protection, cardiovascular disease protection, sleep apnea therapy by limiting and restricting the access, increase workload for us as a clinician when we are challenging the insurance to approve the medications. So there is a system challenge really, which we need to address as clinician And as a society, typically the Liver Society, the Emirates Endocrine Diabetes Society, the Emirates Cardiac Society, and so on and so forth. And it's very important to use a language, and this is the last part of the what we use to ensure that patients take the therapy. So adherence is an issue, ladies and gentlemen. Remember that if you give the treatment injectables for people with obesity, after 1 year, only a quarter remain on treatment. If you give it to patients with obesity and type 2 diabetes, half are on treatment. And if you look at the adherence, which is the proportion of days covered, more than 80% of days covered, then again, about half to 60% are adhering to therapy. So the adherence, ladies and gentlemen, is very poor. Why? Because of GI side effects, because of cost, because we are escalating the therapy quickly. We use the textbook way of doing it when sometimes we should not use the textbook of way of doing it. Access can be a problem. And clinical support, a patient is coming with problem nausea and they cannot see us. They will be given an appointment 3 months when they are vomiting and whatever, and we cannot see them. So what they can do is what? Stop the therapy. So how we can improve the adherence? Easier take medication, reminder system, slow titration, micro dosing, a key thing, very important thing. Intervene quickly when side effects emerge. Maintenance therapy. We need really guidance about what is the best maintenance therapy. It's not the maximum therapy, but what is the best maintenance, long-term therapy, because this therapy is long-term. Using of therapies, giving patient feedback, including CGM. And we know that studies showing that if you give CGM with GLP receptor agonist, then you're going to maximize the benefits. So this is a study from New Orleans 2 months ago showing that CGM plus GLP receptor agonist give you the maximum benefit compared to CGM alone or injectable therapy alone. Many patients, not many, few patients don't respond to therapy well. This study has not reached the prime time, but now the work is to identify the poor responders and the ones who are going to have bad nausea and vomiting. So there are studies looking at the messenger variant of GLP receptors associated with increased side effects and those which are associated with poor outcomes. And they included patients. So according to these investigators, they identified patients according to genetic analysis who are going to do well. And indeed, yes, they did well on therapy. They identified patients who are not going to do well on therapy with minimal weight loss. And indeed, they were predicted them correctly and they did not do well on therapy. So this data, we need to get it in the guidelines. Side effects, we know the side effects. I need to go very quickly because I reached my time. GI side effects, we need to do slow titration, hydration, antiemetic therapy, PPIs, proton pump inhibitors, diarrhea and constipation, modify the diet, rapid weight loss. We don't need a full dose. Educate patients about gallbladder disease. NION, extremely rare, linked to semaglutide only. Support them with mental health. What can I eat? And we just say Mediterranean diet, healthy diet, non-starchy food, lean meat, very important. But then when it comes to the protein with these therapies, that's a topical area. We need to increase the protein intake from 0.8 to 1.2 up to 1.6 gram per kilogram. More than that, we are not going to protect the muscle any further. And the studies are now running 1.2 to 1.6 gram of protein per day. It has been shown beside resistance exercise, very important resistance exercise, plus aerobic, resistance twice a week. This will result in maintenance of the muscle mass, the protein, not in the one meal, but some in the morning, some with lunch, some with the evening meal. Maybe good idea to have a little bit of protein before going to bed, because a lot of muscle synthesis happen when we are asleep. So ladies and gentlemen, tolerability, there are challenges with tolerability, with contraindication. We need really to educate the patients. Muscle loss, so we need to be ready to prevent that. Stopping therapy before surgery, I will say stop food 24 hours, but don't stop the therapy. So only water for 24 hours, and you go to surgery very safe. I don't stop the therapy. Long-term adherence, address the reasons for failure, and support the patients to navigate through the course process. So I think I addressed all these learning objectives. Thank you for your attention, and I'll see you later for the Q&A. Many thanks.
Thank you very much, Dr. Fayyad, for this comprehensive overview on the injectable. And I know it's a hard work to collect all the bits and pieces related to all different type of injectable available currently with us here in a half an hour. So thank you very much for this presentation. We move on to the next presenter. And it's given me great pleasure to introduce a good friend, colleague for a long time, Dr. Hamid Farouqi, who's adjunct professor at Mohammed bin Rashid University, and he's director of Dubai Diabetic Center, as well as the chief of the Division of Endocrinology at Dubai Health. And he's going to present a talk on the new generation of injectable option from now to the future perspective. Dr. Farouqi, the floor is yours. Please put it in.
Thank you very much. So, Dr. Safiya, thank you for the kind introduction and this opportunity to join all of you this evening. So, welcome everyone. Thank you for joining us for this module of Emirates Diabetes and Endocrine Society Summer School of Diabetes. Over the next few minutes, we will cover where injectable therapy for obesity and type 2 diabetes stand today and where it is heading. So this talk is geared more towards our primary care colleagues. So we will from foundations to the decisions you're actually making in clinic every day. So the session has 4 objectives. Objective 1 is about what separates a GLP-1 receptor agonist from a dual incretin agent from a fixed ratio combination. Objective 2 is about matching the agent to the patient's dominant problem, whether it's obesity, cardiorenal risk, glycemic control. Objective 3 is basically objective 3 is with the critical skill of titration and handling the GI symptoms. Objective 4 answers the last question. Does this prescription make the patient's life simpler or more complicated? I want to start with the numbers because they explain why this conversation belongs in a primary care setting as well, not just endocrinology. Diabetes prevalence in the UAE is already high and climbing, and 2/3 of our population lives with either overweight or obesity. The economic burden is already significant and projected to grow substantially in the future. The point I want to make here is simple. The patients who need this therapy are not a rare subspecialty population. They are already in your daily clinic schedule. That's why injectable incretin therapy needs to become a core primary care skill, not necessarily a subspecialty referral unless indicated. Let's take a few minutes to see how fast this field has moved, because that in itself is a clinical fact you need to plan around. We went from a twice daily injection in 2005. I don't know how many of you remember exenatide, but that's what I'm talking about. And to the current once-weekly molecules, then to semaglutide's landmark weight loss data, then to tirzepatide as the first
Dr. Faruqi, can I
Yes.
just interrupt you?
Yeah.
Your voice is not clear. I think we have the same problem as what we had during the rehearsal.
Yeah. So let me just go to the normal speaker from the computer itself. Let me
Sure.
try that.
So is this better?
Yes.
Okay. So we are going back to the slide 3. Basically, I'm sorry, slide 4, which we have right now. So what I was saying was that let us take a few minutes to see how fast this field has moved. So because in itself, it's a clinical fact that you need to think about with regards to how this field has progressed over time. I don't know how many of you remember the twice-a-day exenatide, which we had back in 2005, and from there on to where we are right now, which is our once-weekly molecules. Then we have the semaglutide landmark weight loss data, then tirzepatide as the first dual agonist, and now we have these fixed ratio combinations, which are mainstream tools for simplifying insulin regimes. If you look ahead, there are the triple agonists, the amylin co-agonists, and oral options, which are all approaching or entering the market shortly. The knowledge and experience that you will gain now with semaglutide or tirzepatide will then transfer directly to whatever comes next. It helps to ground everything that follows in the biology, but I'll keep this brief. So GLP-1 basically is the main thing that we are all familiar with in terms of its glucose-dependent insulin release, its appetite suppression, the gastrics emptying, which is slowed down because of that. Then comes the GIP, which is synergistic and seems to improve both the efficacy and tolerability when combined with the GLP-1, which is the basis of the agent that we now use, tirzepatide. The glucagon receptor co-agonism adds an energy expenditure component, which is where retatrutide gets the extra weight loss that it shows. Amylin, via the cagrilintide, works through a completely separate satiety pathway. So each new agent is just not more of the same, it is genuinely different mechanism. So this is basically the injectable landscape that you have. You can see the class of medications that we just went through, the representative agents, the mechanism of how they work, what sort of typical weight loss and percentage do you see with each of these classes, how do you dose them, and where the status is in terms of the UAE approval at this time. So you can use this as a quick guide for reference when you are deciding which family of drug makes more sense to your patient that is clinically in front of you. So let's start with the agents most of you already know about. Liraglutide, dulaglutide, and semaglutide all remain excellent, well-proven starting points. I want to push back gently on the idea that you always need to reach for the newest, most powerful agent for your patients. And sometimes, our patients do come up in our clinics with these preconceived ideas, but we do need to consider the cost, the familiarity, or what glycemic targets are the priority. So if you are looking for a reduction in A1C, for example, along with weight loss, probably liraglutide once a daily may be your choice. Now, out of all of these, semaglutide has been studied the best in terms of the class of GLP-1 receptor agonists. So no other injectable incretin agent has this depth of outcome evidence. Beyond the weight loss and the glycemic numbers you already expect, the SELECT and the FLOW trials are genuinely practice changing. There is a 20% MACE reduction in patients without diabetes, and a dedicated kidney outcomes trial showing a 24% reduction in major kidney events. If your patient's dominant problem is cardiovascular or a renal risk rather than obesity itself, this is the evidence base that you should lean on when you make the choice of an agent. Moving on to tirzepatide, the dual incretin agent. What we know is that GIP doesn't just add efficacy to on top of the GLP-1, it appears to work synergistically, which is likely part of why tirzepatide achieves the largest weight loss of any approved single molecule injectable to date. The SURPASS CVOT also gives us reassuring cardiovascular safety data, non-inferior to dulaglutide with a favorable mortality signal, which is there for us to see. So if your patient's dominant problem is obesity itself, this is usually going to be your most effective single option. In our field, this is honestly rare to get a real head-to-head trial data. So I want to slow down and go over this slide in which we have SURMOUNT-5 and SURPASS-2. Both show a consistent pattern. Tirzepatide outperforms semaglutide on both weight and hemoglobin A1C parameters. Efficacy is only one axis. It is not the whole story. So as we move to the next slide, we'll look at the cardiovascular and renal outcome trials where semaglutide still carries deeper evidence base. Keep that in mind as we move forward, that most effective on these charts or best evidence for your patient's specific risk are not always the same agent which can give you both. So this, in my view, is the single most clinically important slide for our primary care physician colleagues managing the cardiometabolic risk. 4 major trials, 4 different populations, 4 different headline results. The practical message here is don't just pick the agent with the best weight loss number. Pick the one with the outcome trial evidence that matches your patient's actual risk profile. A patient with chronic kidney disease deserves the flow evidence base, as you can see. Whereas a patient with established atherosclerotic cardiovascular disease deserves either the SELECT or SURPASS CVOT evidence base. So this is the data that will help you choose which agent works best for your patient. Now we also have this fixed ratio combinations, and I'll go over 2. One is IGLAR-Lixi, which is lixisenatide and glargine, and ideglera, which is liraglutide and insulin degludec. So they are generally not as commonly used in our practices. As you can see, basically, they are a combination of a basal insulin and a GNP1 receptor agonist in a single pen, and they are given once daily. Where I see the most value is in patients who are already on complicated insulin regimens, or they are going to be on multiple daily injections or a basal bolus combination, whichever term you want to use. For them, this can be a very viable option, a genuine simplification with less hypoglycemia and weight gain, and an alternative to our old friend, the premixed insulin. So this is the slide that I want you to walk away with. So when you ask yourself, what is this patient's single dominant clinical driver? Is it obesity? Is it cardiovascular disease or the renal risk? Is it that the glycemic control is what we want to achieve in this one? Or a simple start is needed? This is where you can find yourself a straightforward answer for these particular clinical scenarios. Each column that you see in front of you, it gives you a reasonable first line answer. Of course, real patients often fit in more than one column, and that's where your clinical judgment and a conversation with the patient about their own priorities comes in. Now to the practical mechanics. I have put the typical starting doses and titration patterns for the major agents on one table, so you can use that as your reference. The single most important principle, which I'll repeat because it is the most common mistake that I see, never increase a dose while patient has unresolved GI symptoms. Slower is almost always better than faster here. So I am repeating what Dr. Tariq Riyad had said earlier, go slow. With regards to managing the GI intolerance, so this is basically one of the objectives of our talk today, and I think the most practically useful one for your day-to-day prescribing. Again, in the same lines as Dr. Tariq had said, most GI symptoms are mild. They are expected because you have learned about them, you have heard about them, and we also know that they resolve mostly with reassurance and simple dietary counseling. If they persist, the answer usually is not to abandon the drug. It is to pause the titration and give the gut more time to adapt. Only a genuine red flag presentation that you can see in the last row, such as persistent vomiting, dehydration, severe pain, these are the ones that should prompt you to stop and reassess and look for an alternative diagnosis like pancreatitis or gallstones. So again, just to repeat, do a gradual titration, go slow. Now, a few practical details here that generally generate a large number of calls or questions for you. So the first one is regarding the injection technique. As you can see, these injections are subcutaneous and abdomen, thigh, or upper arm can be used. Just like your insulin injections, we have to rotate sites and there is no need to aspirate anything. We have to prime the pen as per the instructions that you tell the patient when they start using the device before the first use. And very importantly, disposing of the needles in a sharps container. In terms of storage, you have to refrigerate it before the first use, but once they are out of the refrigerator, they are generally, well, they tolerate the room temperature window, but again, you have to look at the specific product that you are prescribing to your patient. Never put the pen in the freezer, and we have to protect from direct light and heat, particularly in the weather that we have in Dubai as we speak. And if you see that, and you need to tell your patients that if it gets discolored or it's cloudy, unless it's a suspension, or if it is past the expiry date, we don't need to use them. In case there is a missed dose, the general rule for weekly agents is that you need to take it as soon as you remember, well within the week. Otherwise, if it is later in the week, just skip and resume schedule on the next scheduled day. Please never double dose to make up for a missed injection. And the fixed ratio combinations of the daily agents, if it is the one day is missed, obviously you can go on the next day. Again, Repeating, please make sure that they are not expired, they are within the use window for that particular pen. So I want to spend the next 2 slides directly answering the questions I most often get asked. So the first one is, does this patient need an endocrinology referral first? Usually no, but obviously there are the local factors that kick in and the insurance reasons and what have you. Because generally, most obesity and straightforward type 2 diabetes patients can be started in the primary care. However, for type 1 diabetes, if there is recurrent severe hypoglycemia, or personal or family history of medullary thyroid cancer or MEN2, or if you're not sure about the diagnosis, definitely feel free to refer. Now, a lot of people come to us about the thyroid cancer warning, or to be more precise, what about the thyroid C-cell tumor warning? So there is a boxed warning that comes with the medication that says that these are from rodent studies, from rats, from rat and mice, the rodent studies, and there is to date no confirmed causal signal in humans across these large outcome trials. However, we still don't need to use it. It's contraindicated with a history or personal or family of medullary thyroid carcinoma or MEN2. The next question, can I use these in a normal weight patient with type 2 diabetes? If you are using it for the glycemic indication, yes, you may, because if that agent can help reduce the hemoglobin A1C and at a dose that is approved for diabetes, rather than the higher obesity labeled dose, which is intended for patients with obesity. The fourth question, is pancreatitis a real concern? A small early signal was raised, but the large outcome trials, which are your LEADER, the SELECT, the FLOW, some of them were referred to by Dr. Tariq, have not confirmed a clear class-wide increase. So we have to use caution, but not avoid it totally in patients with prior pancreatitis. But once again, be careful, use your clinical judgment. Is it safe before surgery or endoscopy? Now, why is that important? As you remember, that this agent causes delayed gastric emptying. So there is obviously a theoretical aspiration risk. So many of our anesthesia friends, they recommend that we should hold, if it is a daily dose injection on the procedure day, or if it is being given weekly, then the dose prior should be held. And you can always have a discussion with the anesthesia endoscopy team. What about muscle loss with rapid weight loss? So we do know that a portion of the weight loss is lean mass, broadly similar what you see in lifestyle-based weight loss in patients. So here is where you need to advise them to do some resistance training and ensure adequate protein intake alongside therapy, which you saw in the last talk as well. So it is a reason to coach, but not to withhold treatment. The next question is that the patient asks about compounding semaglutide or tirzepatide. What do I say? And this is very common with the advent of social media. We are bombarded with these. So I believe that we should advise against unregulated compounded products. We don't know what sort of quality assurance they have gone through. Is the dose accurate? And is there a safety oversight where they are being made? We would be better off by asking our patients to get licensed products through the Dubai Health pharmacies if they are our patients, or regulated pharmacies where they will get the proper product. Finally, how do I navigate costs and access with my patient? These medications certainly bring up an affordability question, and you need to discuss this upfront with your patients, because this is the main reason why people discontinue. In that event, fixed ratio combinations and older GLP-1 receptor agonists are generally more accessible, and the patient can use it for the long term. So let's make some observations from two cases that I have put together. So patient one is a 58-year-old female with type 2 diabetes for the last 12 years on a basal bolus regime, A1C 8.2, BMI 34. She is having hypoglycemia off and on and thinks that this treatment is a huge burden for her. In this instance, if we consider transitioning this patient to Ideglera once a day, and you then create the dosing for them in a proper manner based on their home glucose monitoring while they switch and they are monitoring, we can, in theory, able to bring the daily injections down from 4 to 1, and we will also have some associated weight loss, and the hemoglobin A1C would improve over the next 6 months. For case B, we have a 45-year-old male with type 2 diabetes for 5 years. They have obesity, BMI is 37. They are already, he's already on metformin, plus a sulfonylurea and a DPP-4 inhibitor. A1C 7.8, and there is, despite this, gradual weight gain. So in this instance, looking at the clinical picture, if we start this person on tirzepatide once a week, we can discontinue the glimepiride because it will cause hypoglycemia in this individual. And sitagliptin, as you saw before, and you know, should not be given concomitantly with the GLP-1 receptor agonist, and instead continued with metformin only. So here, in 6 months, we will see not only an improvement in the hemoglobin A1C, and given the effect of tirzepatide on the weight, you can see up to 15% weight loss, and the regime has been simplified from 3 glucose-lowering agents to 2. So let's, for a minute, look ahead. As you know, and you have probably heard about it, retatrutide adds a third mechanism and pushes the weight loss numbers even higher than the earlier trials with other agents that we have seen. Similarly, cagrilintide pairs an amylin analog with semaglutide. And then there are even longer acting candidates which would require less frequent dosing in early development. And in fact, some of them are being looked into for possible monthly dosing as well, rather than weekly dosing. Now, we know that none of them have been approved for prescribing yet, but this is just a slide to give you an idea of what is coming down the pipe. But as you can see, the trajectory is clear and it is taking off. Now, so this is where we talk about the oral GLP-1 agonist or forglipron. This was approved earlier this year, and it does not have the meal timing restrictions that we had seen earlier with oral semaglutide. So for patients who are afraid of needles or who travel frequently, this is indeed a real option. But at today's evidence, the injectable agents at maximum dose still outperform the oral ones in terms of weight loss. So I want just you to think that this is something that is now available to you in terms of the oral agents, but in terms of efficacy, still the injectables outperform the oral ones. So they should not be thought in terms of replacing. Now, so this is one more way of seeing the whole landscape at a glance by positioning each of these options that you have versus the glycemic control and the weight loss need of your patient. So the green box, the green circle here with the dotted line are the investigational agents, but the other ones, as you can see, are there and available to you for prescribing. So in terms of highest weight loss and high efficacy in terms of glycemic control, you can see tirzepatide. The fixed ratio combinations can give you a good glycemic control, but their ability to decrease weight is somewhat less. So the key takeaway in the end are that the GLP-1 receptor agonists, the dual incretin agonist tirzepatide, and the fixed ratio combinations, they are all available to you, and they sit on a continuum of increasing efficacy and the advantage that their mechanism of action gives you. It's not a strict hierarchy, but as I showed you, that these have a certain level of effect, both in terms of the weight loss and glycemic control. So you need to evaluate your patient clinically and see which is the dominant driver that you need the agent for. So is it obesity? Is it established cardiovascular or chronic kidney disease? And the glycemic proximity to insulin each point towards a different first-line injectable. So the cardiorenal metabolic outcome trials should carry real weight in your mind when you are making that decision. In terms of the dropouts, the way to handle that is to go with slow, structured titration, which will help prevent most dropouts. And generally, this intolerance is transient and is mitigated by slowly increasing the dose and talking to your patients and setting expectations. Don't rush through the dosing. Finally, the best use of these agents is to often replace multiple injections or multiple oral agents with one. So that allows us to simplify our regime and go ahead in terms of achieving sustainability and simplicity. So with that, I would conclude. These are the references, and I thank you all for taking the time to join us for this evening. Thank you very much.
Thank you very much, Dr. Faruqi, for this very informative topic related to the new injectable therapy. And I would encourage all the audience, we have a good number of audience here, please type your questions in the Q&A. And now we proceed to the third talk, which will be presented by Dr. Ali Dibiat. He's a consultant endocrinologist and associated professor of endocrinology. He's the managing director at Newcastle Vitality Clinic here in Dubai. And he's going to present insulin. Does it still play a role? Dr. Ali, floor is yours. Please share your presentation in a slide mode.
Thank you very much, Dr. Fathia, and thanks to the Emirates Diabetes and Endocrine Society for inviting me. Are the slides and the voice clear?
Yes, doctor, please proceed.
Thank you so much. And thanks everyone for joining us this evening, and I will share with you some information about insulin, the hidden soldier actually that has been with us for a very long period of time. I'll review with you the history of insulin type 2 diabetes, move very briefly about some of the treatment landscapes and the landmark clinical trials, but focus more on the treatment situations where we call on insulin as a treatment for our patients, and also how to choose the regime therapy for our patients and how to withdraw it, and end up with a couple of cases that will make what we discuss today relevant. So insulin was the first link between the pancreas and diabetes was established in the 17th century, by the way, by Minosky, when they removed the pancreas of the animal, of the dog, and they discovered that animal developed diabetes. And after a few years, in the previous century, Banting and Best were successful in isolating insulin and enabling the first treatment to become available in 1992. Leonard Thompson was at his deathbed when he was treated with insulin that revived him and allowed him to live moving forward. Before that, it was a death sentence. And he became the first human out of many millions who've been saved by insulin later on. So insulin is not new. It's been with us for over 100 years. But unfortunately, because of inertia, because of fear of injection, and before of legacy, it has been associated with end stage. People used to have different oral treatments, and the approach to therapy was when sugar is too high, we introduce another medication rather than keeping people at target. And when they are drifting off target, we intensify therapy. This is the new approach, and the previous approach led to complications. And unfortunately, after a few oral agents and the patient has many complications, insulin was used, and it was at that stage too difficult to make any major change to patients' trajectory. And that's why it was associated with bad outcomes, not because it is bad treatment, but because the patient was too riddled with complications at that stage to enable to achieve any meaningful outcome. Since then, we had so many treatments, and through this summer school, you've learned a lot about the treatments that are available to diabetes, and you also have learned about the different amazing advancements that has been achieved. We know about metformin, SGLT2s, now cornerstones for treatment, GLP-1 receptor agonist and dual agonist, as Dr. Farouqi have mentioned earlier, and Dr. Tariq. They are absolutely amazing treatments. Also, we have DPP-4 inhibitors as oral therapies, legacy sulfonylureas, and pioglitazones. But what makes insulin stand out from the crowd? It is a safe treatment. It is probably the only treatment that has no interaction practically with any other medication, and also it has no ceiling. All of the other agents, they are either limited by side effect profile, or by a lack of therapy benefit beyond certain dose. Except insulin, the more you give, the more you get benefit of. And that enables it to be able to match those difficult cases to control. When sugar is too high and the patient is not responding to other treatments, insulin comes to the rescue as the most potent and most powerful agent. And there are so many clinical trials that have shown safety and efficacy of insulin. It's not new. The first major clinical trial, landmark clinical trial, was the United Kingdom prospective diabetes study, which was started in the 80s of last century, and concluded that intensifying therapy, regardless of how you intensify it, whether with insulin or other treatments, gives best outcomes moving forward. And it was truly the landmark study that enabled the new philosophy of treating diabetes in people with type 2 diabetes. And even 10 years or 20 or 30 years after the clinical trial, those patients who were enrolled in that clinical trial are no longer, in the clinical trial, still continue to harvest and get the benefit of that clinical trial. When you intensify therapy, you get benefit moving forward in the future. The 4T trial also confirmed that most patients who need insulin tend to progress and need more and more insulin, but insulin tend to be safe. The Origin trial showed that if you start insulin glargine early on, it doesn't have any deleterious cardiovascular benefit even after 6 years. It was cardiovascularly neutral. The Devote trial showed that glargine and degludec, insulin degludec over insulin glargine showed both cardiovascular safety, but less hypoglycemia with insulin degludec. And most recent clinical trial GRADE showed that glargine and liraglutide showed more sustained benefit on the long term. So all those clinical trials showed safety, but also efficacy of those treatments. So what are the indications of insulin therapy? And here we are not talking about type 1 diabetes. It's a given in type 1 diabetes. The only treatment that we give is insulin, different formulations, different delivery types, but it is only insulin. In type 2 diabetes, however, there are indications for insulin, especially like when there is a severe hyperglycemia, when the patient is probably at the outset of diagnosis or they decompensated of therapy, when the A1C is above 10, they are having or glucose is above 300, but also they are having catabolic features like weight loss, osmotic symptoms, polyuria and polydipsia, or ketosis. These are the encounters where we need to give insulin. Those are associated with severe beta cell dysfunction. They are associated with severe insulin resistance. And unless we introduce insulin to offload beta cells and detoxify them by reducing glucose from the glucotoxicity, we will not be able to achieve rescue of those cases of decompensated diabetes. The second one is the drifting of diabetes control. Usually we start with oral therapies. It's a given, very simple and easy. We intensify therapy with second agent, third agent. But after a while, if the other treatments are not achieving control, we should not shy away from introducing insulin as a potent therapy to enable control, not to cause hypoglycemia, but just to bring glycemic control into a safe zone for patients. And the clinical trials and the data, published data, shows on average that used to happen at around 9 years after diagnosis. However, with the advent of all the GLP-1 therapies and the dual and triple agonists coming in the future, this is likely to change. We still don't have true disease-modifying agents like in rheumatoid arthritis and other connective tissue disease. However, it looks like those new treatments, the GLP, the incretin, and the nutrient stimulated peptides tend to change the trajectory of this progressive type 2 diabetes disease. The next one is acute decompensations, when there is diabetic ketoacidosis or hyperosmolar hyperglycemic state. Those are life-threatening cases and certainly need to be treated aggressively. And in those cases, the treatment happens in the hospital. Certainly, the patient is presented with severe dehydration, and the key here is good hydration. Before even starting insulin therapy, good hydration for those patients will enable a reduction in glucose, and when the glucose stabilizes but remains high, then we introduce the intravenous insulin. Taking into consideration the potassium levels and potassium supplementation, taking into consideration whether it is a DKA through ketosis or whether it is only hyperosmolar hyperglycemic state. Because if it is DKA, then the treatment usually starts with 0.1 unit per kilogram per hour as a fixed dose to allow glucose to come down nicely and gently. But if it is HHS, we need to go even slower to avoid the osmotic change in the brain, the potential damage, where the dose is 0.05 unit per kilogram per hour to enable the drop of glucose gently instead of the big shift in glucose. And also, we need to be careful with the euglycemic DKA, especially with the wide use of SGLT2 inhibitors. These amazing medications that are saving hearts and kidneys and enabling patients to live longer and healthier sometimes are associated with the euglycemic diabetic ketoacidosis. In those cases, we need to be very careful on how to manage it, following the local protocols in your hospitals and ICUs, where a glucose supplementation at the outset, as well as potassium and insulin, is indicated along with good hydration and insulin infusion. The next one is in patients who are hospitalized for different reasons, like let's say the patient is admitted for a pneumonia. We know that giving basal bolus insulin and stopping the other oral therapies work in the favor of the patient because, for example, metformin increases the risk of lactic acidosis, especially when the patient is in decompensated metabolic state, when they are acidotic. While insulin is incredibly safe, it doesn't lead to acidosis, it doesn't interfere with any other medications there. Perioperative treatments, especially depending on the case, insulin is the best treatment with regard to interfering with any of the anesthesia or any of the antibiotics or any of the other drugs that are given to patients, especially if there is an underlying condition like heart failure or liver failure or kidney failure. In critical care, patients who are in ICU, the main treatment there is insulin if there is this hyperglycemia. And the new thing that came out from the NICE sugar clinical trial showed that tight control is not advantageous. So if you relax the control, you get safer outcomes for the patients, ranging between 140 and 180 milligram per deciliter. Next one is drug-induced hyperglycemia, and this happens when we give steroids for different reasons, the likes of thyroid eye disease or decompensated pneumonia or a flare-up of COPD. And when we give steroids, you get a spike of like an increase in glucose later on, especially in people with established diabetes. Patients wake up with reasonably good sugar, and after taking the steroids, the glucose increases along the day. And here it is a type of art how to handle that, whether if there is a considerable spike after breakfast where you give mixed insulin, or if it is just a gradual increase in glucose that drops by the afternoon, evening, where an NPH insulin would be sufficient for that treatment. Also, some of the treatments like checkpoint inhibitors that are given in some cancer cases can result in fulminant pancreas failure, beta cell failure. And in those cases, the patient present like a decompensated, newly diagnosed type 1 diabetes, where insulin therapy need to be given immediately and likely to be permanent. Let's take the case of renal failure. In renal failure, almost all the treatments need to be modified, except the ones that are the GLP ones that are independent of the renal pathway, like Dr. Fayyad mentioned. So metformin, we know if we hit the eGFR of 30, we need to stop, and if it is less than 40, we need to reduce the dose. It's not because the metformin hurts the kidney, it's because the kidney is not able to clear it, and therefore risk of lactic acidosis becomes high. SGLT2 inhibitors, when eGFR falls down, they lose their efficacy, and therefore diabetes management becomes less efficacious with those drugs. They will still have benefits with regard to heart and kidney, but from a glycemic control value, they drop down. Sulfonylureas, when the kidney function drops down, increase the risk of hypoglycemia significantly, especially that the kidney is responsible for a considerable percentage of the gluconeogenesis when it is healthy. Insulin has nothing to do with the kidney in terms of clearance. So even in full kidney function or complete renal failure, you can still give the insulin. The risk of hypoglycemia is there because there is reduction of the gluconeogenesis contribution from the kidney and because of the dysregulated adrenal function. But at the same time, it is one of the safest with regard to interaction with other medications. It's the safest with regard to the kidney function itself. So again, with the kidney injury, insulin has a significant advantage to offer there. In pregnancy, we know insulin does not cross the placenta, and it is one of the safest treatment to regulate the glucose in the mother and therefore in the fetus. If the patient has type 2 diabetes and become pregnant, certainly all other treatments apart from metformin need to be stopped. They are not safe, they are not studied, and they can have deleterious effects on pregnancy except insulin. Insulin is the treatment of choice in pregnancy, and there are clinical trials to support that. Metformin is safe. There is some differences between different guidelines about it, but there has been many years of clinical use of it, and it certainly offers a benign way of managing diabetes. But if it is not enough yet, we still have to revert to insulin adjunctive therapy in those cases in gestational diabetes or pre-existing type 2 diabetes. Cost, the other issue. We know that all the new treatments are absolutely amazing, no question about it. But affordability is a major issue. Insurance approvals are difficult. Those who are on cash payment, and in some countries where those medications are not even available, insulin becomes or remains the major treatment that is potent and yet affordable or offered by the government. Majority of the international governments offer insulin free of charge to the citizens, or it is provided at a heavily subsidized cost. So from an affordability point of view, as a treatment, it is a safe and affordable and potent treatment for that matter. In special cases, like in LADA, when there is or double diabetes, when there is type 2 diabetes, insulin resistance, and yet there are the autoantibodies there and C-peptide is dwindling, then giving insulin is key there to prevent ketosis, to prevent the deterioration of the remaining beta cells. And it's one of the best treatments that you give to delay full beta cell failure in that way. Post-transplant diabetes, around the transplant time, the safest treatment for glycemia is insulin, especially around the perioperative time. But even after transplantation, when calcineurin inhibitors, the likes of tacrolimus or cyclosporin given in addition to steroids, a lot of patients without even diabetes develop post-transplant diabetes. And in those cases, some agents can be given, but the safest to start with is insulin. And if the patient has established diabetes, the period after transplantation, the safest management can be with insulin until the renal function is safe to take on the other agents to be introduced. And care need to be given with SGLT2 inhibitors. They are not contraindicated, but care need to be given. They're given the risk of genital and urinary tract infections, especially in a population with a reduced immunity with the immune suppression given for transplantation. Pancreatogenic diabetes, the likes of acute or chronic pancreatitis or pancreatic cancer, or after Whipple surgery where you remove the pancreas, the main treatment is insulin there. You need to treat them as insulin deficient patients. Some cases of chronic pancreatitis flip between needing insulin, not needing insulin, and sometimes they recover of insulin, but the safest treatment is insulin. When the pancreas is removed, the only treatment is insulin, and you treat it like type 1 diabetes. Checkpoint inhibitors, when they lead to fulminant or permanent beta cell failure, the treatment of choice should be insulin, and these patients need to be treated as type 1 diabetes. Cystic fibrosis related diabetes is an interesting one. Again, the safest treatment is insulin, but those patients flip, if you've cared for cystic fibrosis related type diabetes, those patients flip between periods where their diabetes is really badly controlled and they need insulin, they need aggressive treatment, and periods where they don't need much treatment. And this is likely to be related to the inflammation, the waves of inflammation that go through the pancreas related to cystic fibrosis, and also related to lifestyle and the other treatments patients get. In those cases, we need to be at the watch out and to give insulin as needed. And most of the time, HbA1c is not very helpful in those respects, and therefore monitoring glycemia is key there. Some monogenic diabetes and neonatal diabetes require insulin, although when we start insulin, it's the safest and easiest treatment. But later on, once the correct diagnosis is established, some of those patients can be switched to sulfonylurea. Some of the patients don't need any treatment, just monitoring. But those who need insulin should continue on insulin. Now, what are the regimes? And this becomes a way of art, the art of giving the appropriate treatment for the appropriate patient. For example, if the patient has fasting glucose being high and they just need general support, giving basal insulin can be the best approach moving forward. Once daily insulin, and soon we will be having the once weekly insulin in the not far future, becomes a really nice adjunctive therapy to support and offload the burden on beta cells. However, if there are postprandial peaks of glucose, the best approach becomes basal bolus insulin, like type 1 diabetes. And this we see a lot in patients with long-standing type 2 diabetes with burnt out pancreas and beta cell failure. But also we need to be on the watch out. We see this sometimes in cystic fibrosis related diabetes. Premixed diabetes still have a role and should not be discounted. It can be given to simplify therapy. It's twice a day, given before meals. If patients are given basal bolus and not taking it, they'll end up with very poor control because they don't want 4 injections a day. So giving twice a day insulin in this case of premixed insulin becomes the treatment of choice. So it has to be adjusted to the patient's needs and the patient's condition and circumstances. I'll give you 3 quick scenarios just to show you how we can modify the insulin in this context. So we have a 52-year-old lady with a new diagnosis of diabetes, presented with osmotic symptoms and a 10 kilogram of weight loss and A1C of 11.8. So if we go back to the earlier information that I presented, we have newly diagnosed person with decompensated diabetes. So they have catabolic symptoms of weight loss, they have the osmotic symptoms, and they have a high A1C. Those cases, we should be starting insulin until we verify whether this is type 2 diabetes that is decompensated or whether this is type 1 diabetes. And by the way, type 1 diabetes can happen at any age. The oldest person I diagnosed with type 1 diabetes was 83-year-old lady who presented with a DKA. And when we tested the antibodies, came back positive. So it can happen at any age, but those with propensity to it can sustain it earlier in life when they are exposed to the immunological trigger. But that can happen at any age if you've not exposed to the trigger early on in life. So keep that in mind and be safe, because type 1 diabetes, if not treated with insulin, can be fatal. They end up with DKA that has a mortality attached to it. But if they have type 2 diabetes, you don't harm them if you give them insulin until you verify the diagnosis. Case B, 68-year-old gentleman with 12 years history of type 2 diabetes, already treated with metformin, SGLT2 inhibitors, and GLP-1 receptor agonists. So it's on the gold standard treatment, modern treatment. But A1C is 8.9 and eGFR is 28. So the eGFR is declining. They are suboptimally controlled, and they're having a kidney failure. So in that case, you need to stop metformin. You need to adjust the dose of SGLT inhibitors depending on the one, and depending on the GLP-1 you are giving, you need to see whether you need to adjust or not. Majority of the current ones, you don't need to adjust the therapy, and yet you need to introduce insulin here. And that's the safest approach to introduce insulin. Basal insulin, monitor with CGM. If there are postprandial peaks, you may need to switch to mixed insulin or basal bolus insulin therapy. The last case here is to show you how we need to de-escalate therapy and reduce insulin. 74-year-old lady with a basal bolus insulin therapy. She's on a 62 total units of a day in a day. Her A1C is 6.4, but she had a recurrent hypoglycemia. In the past week, she had 2 episodes. Her eGFR is falling down to 52, from 52 to 34. And this is probably due to the reduced clearance of the kidney some of the other diabetes treatments are causing hypoglycemia. So now we need to de-escalate therapy. This is an elderly lady. If she gets hypoglycemia, if she doesn't get a seizure, she may get arrhythmia and she die from it. So this is where treatment is causing harm if we do not de-escalate it. So we need to reduce the bolus insulin, maybe stop it, reduce the basal insulin. Maybe look at the other treatments she is getting. If she is on sulfonylureas, to reduce or stop, adjust the metformin and see how we can take it from there. And very close monitoring of glucose to avoid hypoglycemia. And even if HbA1c drifts up a bit, it's okay. It's not a big deal. It's not going to kill her. But a hypoglycemia with a seizure or with aspiration or an arrhythmia could kill her as well. So this is how we de-escalate insulin. So if someone is on basal insulin, we could basal bolus insulin, we could stop the bolus insulin, we could introduce the GLP-1 treatment with it. If someone is on basal insulin alone, we could reduce the basal dose, we could introduce other non-insulin therapies. The key driving factor here is avoid hypoglycemia. Take frailty into consideration. Look at the weight. If the patient is losing weight, then insulin dose becomes too potent on them. And modify the HbA1c target and look at life expectancy there. If someone's life expectancy is short, don't be harsh. Don't put like aggressive treatment there. Reduce it, relax it. And if they are, and even the diet, you can relax it a bit, but not open completely. The guidelines basically all vary between a fraction on A1C here or a fraction of fasting glucose there, but they all converge on the importance of insulin when it is needed. When there is symptomatic hyperglycemia, we need to introduce insulin. When there is decompensation or catabolic symptoms, we need to introduce insulin. In pregnancy, insulin is the key. In hospitals and in crisis, insulin is the key. So there is an agreement between the different guidelines on this respect. Finally, my message to you is insulin is still a very important tool at our armamentarium, and we should not discount it at all. And yet we should be clever how to use it and know when to stop it and when to start it. Thank you very much for your attention. I'm happy to take questions at the Q&A time.
Thank you very much, Dr. Ali, for this excellent presentation and for all this information that you had provided our audience today. And I just want to encourage our audience that please, post your question in the Q&A. And I know there are a good number of questions now I can see, and we have a good number of attendees as well. And we move now to the next talk. And it's give me great pleasure to introduce my long-term friend, Dr. Huda Azzuddin, who's a consultant endocrinologist who works at the Health Point Diabetes and Endocrine Center. She's a fellow of American College of Endocrinology and a Royal College of Physicians of Edinburgh and London. Huda will be presenting the diabetes and pregnancy. So Huda, please, floor is yours. Just put on a slideshow.
Great. Assalamu alaikum. Thank you so much, Dr. Fathiya and the team for this invitation. I really like the concept of Diabetes Summer School program. It's really nice to feel young and at school as well. And thank you all of you for attending. I'm sure that many of you wanted to hear about the diabetes and pregnancy and diabetes in special populations like the elderly, but because of the time restraints, I'm going to focus on diabetes and pregnancy because I thought we need to pay more attention to that concept. Although the theme is the focus is injectables, I thought I'll just go through an overview about diabetes and pregnancy so that we can know exactly where to fit in the injectables. I would like to focus for the first few minutes on the pathophysiology of the glycemic status and why there is an insulin resistance that is really associated with the progression of the pregnancy, and hence the need for optimization of treatment. And then later on, I'll take you through a journey of managing diabetes from preconceptional phase to during the pregnancy, and then probably if we have time to discuss the post-pregnancy stage. As you all know, that the diabetes is widespread, and the overall prevalence of generally of diabetes or hyperglycemia roughly globally around 20%. And also the prevalence of diabetes in pregnancy is more or less in parallel and is mimicking the overall global prevalence of type 2. So in this slide, where it has been published by the IDF Atlas last year, where the global prevalence of any kind of hyperglycemia in pregnancy is roughly around 20%. And of those, almost 80% is due to gestational diabetes. And you all know that with the progression of pregnancy, the hormones really play a big role in the insulin resistance and the need of support. So in the first trimester, where we have more of the insulin requirements drops, and the sensitivity increases, where patients feel that they are fine and they get more into a little bit of a hypoglycemia. But then as the pregnancy progresses and more gush of placental hormones and the human placental lactogens and the estrogen and progesterone kicks in, then there will be a flip, an increase in the insulin resistance and reduction in the insulin sensitivity. And because of these hormones, it's really important to know the mechanism beyond which we are getting into that state. So the placental hormones, the beta-HCG and the growth hormone from the placenta causes hyperinsulinemia with reduced insulin-stimulated glucose uptake and glycogenesis. And that will also increases some of the subunits of the cytokines in the skeletal muscles that would attenuate the insulin signaling and insulin uptake. Further, if there is any element of obesity, the increasing maternal fat mass causes insulin resistance, as well as an increase in triglycerides almost 2 to 3 times, which leads to inhibition of the lipolysis and increase the free fatty acids, also increases inflammation, endothelial dysfunction, and reduce the trophoblast invasion. With that, there will be a reduced insulin sensitivity, and there is a post-receptor defect in the insulin signaling cascade with the pregnancy. That would also lead to the increase in the tumor necrosis factor alpha, a reduction in adiponectin, which is really, really important during pregnancy. Finally, there is a beta cell adaptation. Because of all of what is happening, there is an increase in the pancreatic cell mass, which is producing the beta cell, that will lead to hypertrophy and hyperplasia with further insulin secretion driven by placental hormones. And failure of having that adaptation, then there will be accumulation of the glucose in the milia. So in a normal pregnancy, where we're getting more of a progesterone and more of the human placental lactogens and growth hormones, there will be a more proliferation of the pancreatic cells and more of a lipolysis and reduced in the insulin sensitivity. And a lot of these are driven by a reduction in of adiponectin itself, because adiponectin itself causes increase in beta oxidation, reduce apoptosis, and increase the insulin secretion itself. And failure of having that, then there will be the opposite of what we are seeing now in normal circumstances. So in a normal pregnancy, as I said, the pancreas will have more stimulated insulin secretion, the cells will increase in size and number, and there will be a more ability for tackling all the blood glucose that is concentrated in the bloodstream. Whereas in a gestational diabetes, the pancreas actually and the beta cell fail to compensate for the high demands of pregnancy with a concomitant reduced insulin sensitivity, and that would result in hyperglycemia. So back to the slide again, in comparison with a normal pregnancy, we will get in a gestational diabetes the increased immune cells and increased inflammation, high insulin resistance, and of course the lipotoxicity and glucotoxicity. The ultimate outcome of all what is happening is detrimental. Whether we're dealing with a pre-existing type 1 or type 2 diabetes, or in women who develops later on a gestational diabetes. And you can see that we're having a negative impact of hyperglycemia to the fetus, to the neonate, and to the mother itself. I don't want to go into each one individually, but you can read through. I have to just focus on or emphasize that the women in gestational diabetes is not something simple. It can really cause a preeclampsia, and it can really increase the lifetime risk of diabetes mellitus in her and as well as in her offspring. I can't go any further with any presentation about diabetes in pregnancy without just mentioning the major landmark study about the HAPO study, the hyperglycemia and adverse pregnancy outcome, where it really looked at any level of increased blood glucose level, even within the normal range, can have a negative impact on birth weight, an increase in primary cesarean section, and a neonatal hypoglycemia, as well as the elevation in the C-peptide above the 90th percentile in the fetus. Excuse me. And those were primary outcomes. And the secondary outcomes as well from the HAPO study showed an increase, statistical increase in the prevalence of premature delivery, shoulder dystocia, birth injuries, intensive neonatal care admission, hyperbilirubinemia, and also there's a continuous linear association with even the first hour plasma glucose level as well as the second hour plasma glucose level and fasting. So any of these three indices, if we have an elevation of those, even within the normal range, we will have an abnormal consequences, unwanted consequences in the mother as well as in the fetus. Moving forward, the same authors and other authors as well looked at a follow-up study of the HAPO study. So they've looked at the maternal GDM and childhood glucose metabolism. And if the original HAPO was published in 2008, this was published in 2019, following up the offspring exposed to untreated gestational diabetes in utero. They were found to have insulin resistance with limited beta cell compensation compared with the offspring of mothers who did not have gestational diabetes. And therefore, GDM is significantly and independently associated with childhood impaired glucose tolerance. And because of that, a lot of emphasis was put by scientific authorities looking at the preconception management of women, whether women with high risk of dysglycemia or women with pre-existing type 1 or type 2. So in normal women, but then let's say she had a family history or she had a previous GDM, we need in the preconception phase, we need to offer her a 2-hour 75-gram OGTT based on the WHO criteria. And this is a lifetime management that we need to focus and inform the woman. Whereas women with pre-existing type 1 and type 2, we need to optimize the diabetes education and lifestyle management, advice against unplanned pregnancy, maybe offer contraception. And we need to ensure that her pre-pregnancy A1C is less than 6 to 6.5, at least 2 months prior to conception. Her medications needs to be optimized, whether we're talking about insulin or metformin. We need to provide folic acid, and we review her blood pressure medications if she's been on blood pressure medications or for renal protection. The ACE and the ARB and the thiazide diuretics needs to be switched to labetalol, nifedipine, and methyl-dopa. Regarding the statins in pregnancy, I mean, years ago, we were informed and taught that statins needs to be stopped like 6 months before getting pregnant, but then this is a little bit unpractical, especially in women who are diabetics and having high cholesterol level. But recent studies and guidelines suggest that we can stop statins as soon as pregnancy is confirmed. We would need to screen for comorbidities as well and tighten up the glycemia and the control as much as possible. Remember that preconception glycemic goals are the preprandial glucose needs to be around between 80 to 110, whereas the 2-hour postprandial should not exceed the 155. This is whether we're talking about women with pre-existing diabetes or women who are just on the verge of it. This table, I tried to summarize the differences between different organizations and the screening protocol for diabetes in early pregnancy guide. So if we look at the ADA or the IDF or WHO, so all of them actually advocate for early pregnancy screening for diabetes. Some of them looked at or suggest or advocate for selective screening for type 2 diabetes based on the risk. Others, like WHO or IDF, actually recommend a universal screening because of the high prevalence of type 2 diabetes. But you can go through actually all of these guidelines and the high risk indicators or the triggers for early screening. I mean, this is nothing that this is new on you. We're talking about a BMI above 25 or 30 kilogram per square meter, or a family history, first degree of diabetes or high prevalence, minority or race. And then the tool that is used also sometimes differs. Some people advocate for the standard non-pregnant threshold that can apply for non-pregnant women, or others can advocate for like women prior to GDM. They can offer a 75 OGTT at booking on the first visit to the antenatal care. It would be nice, since we have, mashallah, a good number of you, just tell me if any of you actually prefer any one of those guidelines, the ADA or the WHO or IDF, if you follow and do screen for diabetes in early pregnancy, since our patients, almost all of our patients, are at high risk of diabetes. Going further from screening for diabetes in early pregnancy to screening and diagnosing gestational diabetes later in pregnancy. Again, the organizational authorities, they differ in their guidelines. Some advocate a 1-step, others the 2-step. It all depends on their population, the population studied. So if I would pick one, maybe the WHO, it's a 1-step approach. The early screening would be beneficial. We can, again, the window of screening between 24 to 28 weeks of gestation, this is common amongst all of them. But then the difference comes in the threshold. If you pick the 1-step or the 2-step, the differences are small, but then can be confusing. And where I work, I practice is the 1-step 75 grams OGTT, and then we need 1 or more value that can meet those criteria: a fasting more than 92 milligrams per deciliter, first hour should not exceed 180. If it exceeds 180, then we have a GDM. And if it increases 153 after 2 hours, then we're dealing with a GDM as well. Again, I would like to know if you follow any of these organizations for diagnosing GDM in your practices. This slide was meant just to put things together to avoid confusion. So if I have a pregnant woman at first prenatal visit, ideally before 15 weeks of gestation, we just need to ask ourselves, is that patient high risk for developing diabetes? If she's thin and slim and no family history and she's the ideal pregnant woman, then there's nothing to be done at this stage, just routine pregnancy care. And then just consider having a GDM screening at 24 to 28 weeks of gestation by using the one-step 75 grams OGTT. But if we are dealing with a lady who is having an obesity or prior GDM, family history of diabetes, then she is at high risk from the beginning, and we would really look at her, perform the early screening as if she is non-pregnant with the A1C or fasting blood sugar or random blood sugar. Compare these results with the non-pregnant thresholds, and if we have an abnormal result, then we can initiate the treatment immediately as pre-gestational type 2 diabetes. But if the result is borderline or in doubt, then we would need to perform the 75-gram OGTT. From that, I move on to the monitoring. So because of the continuous hormonal and biochemical and other physiological changes that take place during pregnancy, and it would result in significant insulin resistance, this glycemia should always be monitored regardless of the feeding status. So I wouldn't buy women saying, oh, my fasting is this, and then forget about the rest of the day. So at any point in time, a pregnant woman blood glucose need to be under control. So what do we use for monitoring? The IDF recommends blood glucose monitoring by the finger prick, the capillary, 4 to 7 times per day. Once glycemia is controlled, monitoring can be reduced to 2 to 3 times per day. The American Diabetes Association recommends the use of continuous glucose monitoring system in women with type 1 diabetes, of course on insulin, but there is regarding the type 2, there is insufficient data to support the use of continuous glucose monitoring system in type 2. However, a lot of our patients who are on insulin, known to be type 2 and on insulin, would benefit from having the continuous glucose monitoring system, maybe coupled with the capillary SMBG, just for making sure that we're not missing hyper or hypoglycemia. And we need to individualize the use of CGMS because of the cost issue in GDM as well. Once a patient, and from insurance purposes, once a patient is on insulin, then I feel that continuous glucose monitoring is really worthwhile. I'm presenting now the glycemic goals in pregnancy associated with the diabetes. So the first panel is any woman with type 1 diabetes or type 2 diabetes. The goal is to have a fasting blood sugar between 70 to 95. So this is the ADA standards of care. But if we have a patient on the GDM, the figures are identical if a GDM is treated with insulin. But then if a woman gestation diabetes is not treated with insulin and only with the diet or with oral, we need to be more aggressive to a level of fasting blood sugar less than 95 and the 2 hours postprandial less than 120. Whenever a woman starts insulin, we just need to make sure that we're not going into hypoglycemia, where the current recommendation for a hypoglycemia threshold include a blood glucose of less than 70, and the sensor glucose is less than 63 milligrams per deciliter. So do not mention the figure of hypoglycemia unless we know the tool that the woman is using to check her glucose with, whether it's a sensor or it's just the monitoring from the finger prick. The continuous glucose monitoring sensor targets range in pregnancy is sometimes it is really important to identify the time. What is the percentage of the target range in a 24 hours there? So we wanted to have the majority of her readings within the target, but definitely not less than 70%. And not more than 25% should be in the higher zone. We understand that those patients who are on the CGMS and follow these goals are probably on insulin. So the CGMS user glycemic goals, for those who are non-pregnant, you can see that, again, we wanted to have the majority of their readings more than 70% within the target for type 1 and type 2. And in women who are not pregnant or older individuals, we can come down to the target to be more than 50% if we feel that that patient is more at a higher risk of hypoglycemia. But when we wanted to talk about pregnancy, then these are the targets: pregnancy in type 1, and pregnancy in gestation diabetes, and type 2 on sensor. And we need to have the majority of the readings within the target. I just want to inform you that please make sure that when you do the downloads, you need to adjust the download measure, the range, that it should be between the 60 and 140. Otherwise, by default, the download is fixed to 180. And if it is 180, you will have a lot of apparently normal readings, but they are more than 140. Now that we have identified patients who are at hyperglycemia during pregnancy, of course, we cannot ignore the medical nutrition therapy and the physical activity. By itself, this needs another hour to discuss in detail. But the use of insulin, primarily insulin, with or without metformin, is really crucial. So insulin, we start the insulin with or without metformin if we have a fasting blood sugar of more than 126 or the 2 hours postprandial more than 200. So this is diabetes range. So once we have a pregnant woman with these figures, immediately we have to really use the insulin. You can add to it metformin or not, but those are diabetes ranges, and we don't want to take chances. We can consider the insulin if the fasting blood sugar is a little bit less, especially if we have some complications. We add insulin if the targets are not achieved in 1 to 2 weeks, not 1 to 2 months. So we're talking weeks now. So from the starting of metformin. So if you have a patient with a gestation diabetes or a metformin-treated diabetic, after 1 to 2 weeks, if it is not achieving the goals, then add insulin. Do not save it till the very last minute. Some women can benefit from glibenclamide. I'll come to that point later. In case of intolerance to metformin, and if the patient consistently is refusing insulin. We know that pregnant women with type 1 or type 2 should be prescribed low-dose aspirin, starting at 12 to 16 weeks of gestation, just to lower the risk of the preeclampsia. This table, again, I tried to show you the differences between the 3 main pharmaceutical agents that can be used during pregnancy. Obviously, insulin is the mainstay, and the insulin is the only really FDA approved for the treatment of diabetes. When it comes to metformin, it's not that FDA approved for, it is approved for type 2 diabetes, but not specifically FDA approved for gestational diabetes, and likewise the glibenclamide. So just know those differences. We are using, for example, metformin off-label use in patients with gestational diabetes, and not because of its FDA approved, even though the risk of harm is very, very low. Which one crosses the placenta? Insulin is a high molecular weight protein, as does not, and no clinical significance placental transfer, whereas metformin and glibenclamide, they do cross the placenta. Which one causes more maternal hypoglycemia? Obviously the insulin, and the metformin has a low risk of developing hypoglycemia compared to glyburide or glibenclamide, which causes higher risk of developing hypoglycemia as it stimulates the pancreatic insulin release. The long-term fetal offspring, extensively insulin were studied. Everything seems to be safe and fine. Metformin, there's a long-term effect remain an area of uncertainty because of fetal exposure that can occur. And the glibenclamide long-term safety data are insufficient. Talking about metformin and later on other injectables, I just wanted to highlight that this is a recently published article looking at it's a systemic review and meta-analysis looking at the safety of metformin during pregnancy in women with gestational diabetes. So in this major paper, the metformin was associated with statistically significant reduction in the neonatal hypoglycemia and lower birth weight, with a significant reduction in preeclampsia and a non-significant trend towards reduced large for gestational age. There is no significant difference in the incidence of prediabetes, diabetes, or insulin resistance thereafter were found. But then we need more evidence and maybe on a long-term evidence to freely advocate for metformin during pregnancy. But so far, I know that all of us are prescribing it during pregnancy, and the level of certainty of safety is probably high. What about now the safety of GLP-1 receptor agonists in early pregnancy? You know, it's really a luxury to plan pregnancy in Arab women. And what happens most of the time is accidental pregnancy without any preparation, unless patients are going through IVF or assisted fertility. So these two recently published in major journal, the one on the left is by JAMA and the one on the right by BMJ, it just reassured users and prescribers about the unintentional use of GLP-1 in early pregnancy up to the end of the first trimester. So the one on the left, the safety of GLP-1 receptor agonist and other second-line antidiabetic in early pregnancy, there was no increased risk of congenital malformations even after periconceptional use of sulfonylurea, DPP-4, GLP-1, SGLT2 compared with insulin used in about 50,000 women with diabetes. This does not mean that we should continue prescribing those medications for patients who are planning to get pregnant, but at least there is enough evidence to reassure us that hopefully nothing bad will happen to the fetus or to the mother. The one on the right is specifically for GLP-1, and there was no association between GLP-1 receptor agonist exposure and an increased risk of major birth defects. I like this table that looked at specifically the pharmacokinetics of GLP-1. So those are actually big molecular weight proteins that do not necessarily, in normal circumstances, cross the placenta. But then looking at their half-life, the semaglutide 7 days, the liraglutide 13, and the tirzepatide 5 days. So how much time do we need before we can tell the patient, yes, you can go ahead and stop the medicine and then fall pregnant? So we need roughly around between, especially for the long-acting GLP-1, the semaglutide and the tirzepatide, around a month, let's say. But that doesn't mean that we need to carry on continuing the patient to take it until she falls pregnant. If she's really planning to get pregnant in a month or two, we need to stop it now. Now, the ADA recommendations, the latest for the postpartum care, insulin requirements need to be evaluated and adjusted after the delivery immediately, because the insulin resistance decreases dramatically after the birth of the placenta. Contraceptive plan should be discussed and implemented with all patients with diabetes. We need to advocate for breastfeeding in all individuals. It is recommended for individuals with a history of GDM with multiple benefits, and it reduces the risk of type 2 diabetes later in life. We need to make sure that we tell the patients that she needs to come back and screen with for those who had a recent history of GDM and screen for postpartum dysglycemia with the 75-gram oral glucose tolerance test using the non-pregnancy diagnostic criteria. And how often do we need to repeat that in women who are having gestational diabetes history or high risk of diabetes? We need to repeat that test every 1 to 3 years. We have mentioned that actually in our latest guidelines, as the patients with history of gestational diabetes is at high risk of becoming diabetic, pre-diabetic in the following 5 years following delivery. Individuals with overweight or obesity or history found to have a pre-diabetic should receive guidance and weight management. In conclusion, I just wanted to wrap it up that we have so many patients with diabetes in pregnancy, almost 1 in 6 pregnancies, and any level of hyperglycemia can be detrimental. We need to make sure that we have a universal screening for diabetes in pregnancy. The main thing is to advise for the standard diabetic diagnostic criteria. And if negative, repeat a formal 75 OGTT between the week 24 to 28, and these are the figures. The targets continue to be fasting less than 92, 1 hour less than 140, and after 2 hours, 120 milligrams per deciliter. Insulin, with or without metformin, is safe and are preferred over glibenclamide, and the GLP-1 receptor agonists need to be stopped 1 to 2 months before planned pregnancy. And then at the end, women with a history of GDM needs to have the postpartum screening 4 to 12 months after delivery with the 75 grams OGTT followed by repetition almost every 1 to 3 years. With that, I come to the end, and thank you for your attention.
Thank you, Huda, for this very informative talk related to the hyperglycemia in pregnancy. So we have, a couple of questions in the chat box. So if I just start my first question and I address that to Dr. Tariq, which GLP has not added benefit beyond glycemic control?
Sorry, which GLP?
Which GLP had no added benefit beyond glycemic control?
Well, all GLP receptor agonists have additional benefit, right from the old ones, exenatide, lexasenatide, up to the most and the strongest tirzepatide so far. But obviously, the magnitude of impact into, let's say, the weight is highest, as we know, with tirzepatide, followed by semaglutide, followed by liraglutide, followed by dulaglutide. So that's really maybe when it comes to the weight. And then when it comes to cardiovascular, so there's another thing beyond the glycemic control. Then I think we have the evidence from the old ones, liraglutide, dulaglutide in Rewind study, and we have the evidence from Sustain 6 and then with tirzepatide as well, and dulaglutide. When it comes to the HFpEF, we have evidence from the 2 weekly ones. And when it comes to MASH, again, we have evidence from the 2 weekly ones. And when it comes to sleep apnea, beyond the glycemic control, the data is confined to tirzepatide.
Right. Thank you very much for this. Dr. Farouqi, are oral GLPs at the same efficacy as injectable?
The simple answer is no. The injectables are better, but by no stretch of imagination, orals are, really weak. No, they have a pretty good efficacy, but not as much as injectables.
Right. The other questions to Dr. Ali. When do you consider insulin before GLP?
So it's a very good question, actually. I would look at the patient's case, and if they have catabolism, if they are losing weight, then insulin need to be introduced at that stage. And if the patient is underweight, for example, if you give them GLP-1, they will lose even more weight. So every person is different. Yes, the majority of patients will consider GLP-1 before, but that is in classical, progressing type 2 diabetes. When the patient is losing weight and there is potential for type 1 or LADA, or when the patient is underweight, or if there is history of pancreatitis, the other contraindications that are already established, then we consider insulin.
Right. Thank you for this. Huda, which long-acting insulin is approved during pregnancy?
So this is a good question. What is approved is the Glargine is approved. Tresiba is not fully approved, but then we're still using it. And there is no actual contraindication to continue if we feel that the patient is at high risk of hypoglycemia. The objective is to control the blood sugar. And the duration of using the insulin during pregnancy is just limited unless the patient is already on insulin before or after, we're talking about type 1 or type 2 on insulin. So even if we're thinking that this might have any detrimental effect, it does not happen. And even long-term studies with Tresiba did not actually confirm that this can have any abnormal side effects. So whatever can put the woman on target, we're going to follow.
Okay. Thank you, Huda. These are the questions I've just came to across my mind, but there are, a couple of questions also on the chat, which I'm going to take them now. So my question to Dr. Farouqi, probably you presented on this, and just to emphasize on that, when the GLP should be stopped prior to the anesthesia, is it a day or a week prior to the anesthesia, as we are nowadays in this era of, of the use of these medication?
Okay, so it depends on the fact whether you are giving a daily GLP-1 or you're giving a weekly GLP-1. Why? Why is it that it needs to be stopped, as I had mentioned? Because it delays the gastric emptying, and therefore the chances of aspiration while under anesthesia would go up. Therefore, we need to, if it is a weekly one, the dose before the scheduled operation or, investigation, whatever, or endoscopy, whatever the case may be, we need to stop that. And if it is daily, the day before.
Right. Thank you for this. Dr. Fayyad, how can a patient on MDI be switched on a fixed combination, and how it will be up-titrated with a fixed dosing of GLP?
Generally, if a patient is taking basal bolus, obviously it's important to cut down the dose of the basal as well as the prandial insulin. It generally depends on their prevailing glycemic control. So if they are very poor control, then I'll cut it down maybe by 25%. If they are good control, I may go as down as 50 and introduce the combined, you're referring to combined GLP and insulin, isn't that right? That's what
Right.
That's the question. So I'll start that in the standard dose of 10 units of combined dose units. And as I uptitrate the combination by 1 unit every day, I will cut down the basal insulin by 1 day So one combination is going in, and the other one is coming out at the same rate. And I'll pay attention to the postprandial to cut down the prandial insulin level. So I think that depends really on how good the control was before introducing the fixed dose combination.
Right. Dr. Ali, if the patient interrupted his GLP management and they just resumed it after a period of interruption, will they get the same weight loss or the same degree of the weight loss?
So depending on how long the interruption is and how did they go back to the treatment. So if they stop the treatment for a long period of time and they resume same lifestyle that led to weight gain, they would have gained weight, for surely, because their body declared they can do weight, they can increase weight. If they resume the treatment, from our experience in the first generation of GLP-1s, first and second generations, there was a bit of tachyphylaxis. So you start the treatment, you don't get as much benefit. With the newer generations, the weekly ones, we are getting more or less similar benefit after an interruption. Although some people cannot tolerate higher doses. So when they interrupt the treatment and they go back to it, for example, for tirzepatide, if they were on 15 milligram and they interrupted and they go back to it, some of them get stuck at around 5 or 7.5 and they cannot continue at a higher dose because of side effects. And some patients don't get much benefit and they need to continue to 10, 12, and 15 milligram with less weight loss as a net until they reach 15 milligrams. So it varies a lot. But with first generation, it used to get tachyphylaxis. Patients not lose much weight if they stop and restart again.
So is it a good practice that most of our patients sometimes who come to our clinic, to save on the amount of the GLP and also because of the cost of it, they themselves, they take it, bi-weekly or, once per week. This is a right practice if we come across such patient?
It's a very interesting question. Obviously, there is no clinical trials to support this. I think the only clinical trial we have is from tirzepatide reduction to 5 milligram, and we see some weight gain there. But anecdotally from clinical practice, from those patients who tried to do this, we find that those who are at a high dose, let's say 10 or 15 milligram, and they're no longer losing weight, and for some reason they stop the treatment, or if we reduce the treatment down to 5 milligram and push it back again, they resume weight loss. Maybe that will kickstart their weight loss journey again. So these are not supported by clinical guidelines, or clinical trials, but they seem to be a safe approach to it. However, giving it every 2 weeks is a little bit of a risky practice because of side effects. We know from the half-life of the treatment, it's about 5, like the safe level remains, or like the treatment level remains until about 5 days or so, depending on the molecule we are using, and then starts to drop. By 14 days, not much of the treatment is in the system. And if they are on a high dose, every time they are hitting themselves with a higher level of treatment, they may be tolerating it, but if they get a little bit of gastrointestinal infection, they may end up in hospital, and we've seen this on few occasions. So it's not a good practice, but some people do it on their own risk.
Okay, thank you. The question to Dr. Fayyad and Dr. Farouqi together, because I think both of you had touched on this while you are presenting in relation to the muscle loss, and you already alluded on, how to take care of this once we prescribe the GLP. But the question here from the audience is: the injectable cause the fat loss and wrinkling as well? And are we as a physician doing enough to educate our patient or refer them to our educators or clinical nutrition in terms of education related to the muscle loss? But I would like to know about the fat loss and the wrinkling. It's interesting. So Dr. Farouqi or Dr. Fayyad, anyone would like to start?
Okay, I think, my starting point is that every patient on this treatment is going to lose both fat and muscle. And that's regardless of whether it's injectable therapy or dieting or bariatric surgery. So losing muscle along with the fat is normal. And it makes sense because when you are light, you don't need a lot of muscle to carry you. When you're heavy, you need a lot of muscle to carry you. But then the question is, how much of it is fat and how much of it is lean body mass, or if you want to be more specific, skeletal muscle mass, SMM. So with that regard, the data is showing that the percentage of fat that you're losing with the therapy, GLP receptor agonist or dual agonist, is more than the muscle mass that you're losing. So at the end of the day, your body composition in the whole is going to improve. Not only the mass itself, but also the functionality of the muscle. So function of the muscle tend to improve as well. So you'll be faster running, faster in getting up the stairs, and so on and so forth. Having said that, there's a concern about sarcopenia, particularly in the elderly patients, and so on. And therefore, and this subject is coming more and more now. It's very important that we explain to the patient the way we explain to them about the nausea and how to mitigate it and so on and so forth. We need to explain to them about the importance of taking enough protein and spread it throughout the day, in the morning, at lunchtime, and even at bedtime, because that will help the synthesis of the muscle while we are sleeping. And then studies are being done now on the treatment, and they found that you can increase your protein intake while in GLP therapy from 0.8 up to anything between 1.2 to 1.6 gram per kilogram. And that will give you the ideal protein supplement. But very important, the caveat is resistance exercise at least twice a week is paramount in order to keep those muscles.
Right. Dr.
So,
Farooqi?
yes, ma'am. Very quickly, I want to add a couple of things that we need to keep in mind. First, what is the BMI that you're starting with, and how fast are you going to lose? And we have seen that if the weight loss is really rapid and significant, yes, the skin is going to go lax because that is what it was containing to begin with. Now, the important thing is, as Dr. Tariq said, the diet bit, the exercise bit, and this is where your multidisciplinary team comes in. So the doctor, the nurse, the educator, the dietitian, all have to kind of, get together around the patient to help them in that transition that is going to happen with the weight loss. Now, how to handle that? Dr. Tariq told you about the exercise bit, the diet bit. So I'll just conclude by saying a message that came to me from one of our patients today, and that patient was convincing me that I should tell everybody to go for gradual weight loss, otherwise the lady would look very wrinkled very soon. So yes, that is basically, what I would say in response to that question. Thank you.
Elasticity of the skin.
Yes.
Thank you for both of you. Huda, now many of our patients, they are using GLP. So is there any side effect, once it's used on the long term, like let us say a lifelong of someone maintain on a small dose?
Are we talking about pregnancy or outside pregnancy?
No, outside pregnancy.
So you know that the recently launched tirzepatide and the semaglutide were in the market for the past, let's say for tirzepatide, 5-6 years, and the other one maybe 10 years. So beyond that, we don't know. So the best thing is that what we know for now is reassuring in terms of long-term use of it. Even patients who've been using it on and off, because at the end of the day, if you're not diabetic and you're taking it for weight loss, you would achieve your target maybe within the first year or 18 months. And most patients they get bored of either buying the medicine or either they want to go back and eat or enjoy life. But the majority, the compliance becomes an issue after maybe 8 to 12 months. And then we see that pattern of on and off being on the medicine, on the GLP-1. I did not see any major side effects to this, except that instead of having the second cycle of GLP-1, instead of having like 100 kilograms, now they are starting it with like 90 or less. So they are still less heavy, a little bit more active, and they know what to expect. So to answer your question, we don't know what can happen beyond 15 years, from the beginning of the first person who used these agents. I just wanted, because I've seen in the chat box, one person asked about why is it contraindicated or not advisable to use the SGLT2 during pregnancy or the GLP-1. So if you allow me, I will just answer that person. So SGLT2 crosses the placenta, and it can actually interfere with the organogenesis or the kidney function of the fetus. So we don't want that. Plus, it was not studied at all because it crosses the placenta. With the GLP-1s or GIP, those are big molecules. Normally, they are not expected to cross the placenta, but we don't want women who are pregnant to use them because we don't want her to be losing weight while we want her to gain a little bit of weight during pregnancy. So weight loss in pregnancy, not maintaining the weight, is not advisable, and we don't want a woman to be in a catabolic state as well. Beyond that, those are really nice. GLP-1s are nice.
Especially ladies advocates. Dr. Ali, thank you, Huda, for this. Dr. Ali, now there's a long question in the chat box, but I will just try to summarize it. A patient with type 2 diabetes, A1C of 10, he has some behavior, he indulged in eating because of the psychiatric illness, and the physician recommended liraglutide, but the BMI is around 18, and the mother is hesitant with the weight loss in a minimum dose. So what is the best, for this patient? He's already on insulin.
How old is the patient? Because BMI of 18 is like underweight for adults.
It's young patient with some mental health issue.
Okay, so in this case, it's very important to to control glucose, because diabetes at this age deleterious. Like the outcomes on the long term are far worse than someone who is like fully developed in their 30s or 40s who develop diabetes. Insulin is a good choice, but unfortunately, it can increase weight in this context. Giving GLP-1 treatment is the best approach if the family are agreeable. And now we have the oral options. If the objection is about the best approach here is having a deep and understanding discussion with the mother and understanding her concern. If we go by license, the only licensed medication for this age group is liraglutide and semaglutide, actually, injection. But the oral option probably would be use of license as a compromise if the objection is injection. If they don't want injectable therapies, maybe we can give oral GLP-1 receptor agonist. That would be the best, because that will suppress appetite, that will reduce insulin resistance, which is related to the antipsychotics, and reduce the drive. That would be my approach. Otherwise, any treatment, really, metformin should be the base there if the patient can tolerate it, to control glucose, because hyperglycemia at this age will have a very severe tax later on in life.
Right. Extension to your talk, you presented on different type of insulin. One of the colleagues asking that they have 2 reported cases, which is with insulin allergy. So have you ever came across such thing? And if that is the case, which insulin, can cause allergy? And do you think that it is safe to change it to another type of insulin? Now we have so many on the market.
Very important question, and this is like one of the nuances of insulin therapy that we've learned over the years. It's not common. The true IgE-mediated allergy to insulin is about 0.1%, and mostly related not to insulin itself, but to the excipients with it. For example, the NPH insulins, the protamine, which is a fish protein, or sometimes to phenol, that is the preservative and disinfectant that is packaged with insulin. But insulin itself, we know from humans that we can produce antibodies to it even in type 1 diabetes. So the first approach is to go with insulin without additives, which is the regular human insulin, to start to see if it is like it's an allergy related to the insulin molecule or to the additives of it. The second one, avoid any additions like the additional zinc or protamine in it. So go for the analog insulins that are analog but not identical to human insulin in that way. And probably do the IgE titer to see if it is a true insulin allergy or not. It is reported, but mostly it's local allergy, local irritation, but true anaphylactic cases have been reported, certainly, but incredibly rare.
Yeah, probably maybe they've been using the oldest brand of insulin, which we all are familiar with, that can cause, and usually we end up by doing a desensitization for our patient. This is what was the practice in the past. There's a question which always come to our, clinics, and I think in every webinars we do, and I think in every meeting we go, or even visiting family member, whether the GLP can cause, problem with the liver function test, with the amylase, lipase. Sometimes that's the practice of some of the physician who will require, will request amylase and lipase. So I just want the input from Dr. Fayyad with regard to, the check or the testing the amylase and lipase in the practice. And the other question to Dr. Faruqi, which is, again, you already mentioned that in your talk, whether we require to do a screening prior to start on GLP of TFT or ultrasound, for example, once we start them on one of the GLP, including the tirzepatide. So Dr. Fayyad first.
Okay, so thank you for the question. As far as the liver, obviously, all GLPs without exception are good for the liver. But the best evidence comes from the 2 weekly molecules. When it comes to the measuring of the amylase and lipase, this is something which is discouraged. We shouldn't do it. We know very well that on treatment, regardless of the type of GLP or dual agonist you're using, you would expect an average 2 to 3 times increase in the amylase and lipase, and that's probably related to stasis. It's nothing to do with inflammation of the pancreas. And therefore, the starting point is that we should never test amylase and lipase unless there are typical acute symptoms suggestive of acute pancreatitis, like severe epigastric pain, radiating to the back, etc., etc. But if the patient already had pancreatitis because of this therapy, we should stop the therapy immediately, and we should not resume it once pancreatitis has resolved. So that's the situation. So do not measure amylase and lipase in these patients.
All right, thank you. Dr. Faruqi, thyroid issue?
Yes. So the first point is that there is no such recommendation that we should be checking the thyroid profile or the thyroid ultrasound in any patients normal who are going to be started on this agent. If, however, there is somebody who has a multinodular goiter, well, then treat that on its merit, not because you are starting somebody on a GLP-1. The third point is that, as I said earlier, that if there is a history of MEN2 or medullary thyroid carcinoma in the family, then you're better off not starting it. So those would be the main points with regards to the thyroid.
Right. Thank you. one more question. I think, Huda, you already answered the SGLT2. Now, Dr. Ali, is insulin cardioprotective and reduce MACE or not?
It's a very good question. I think probably the strongest evidence comes with UKPDS. I mean, there are a few clinical trials that showed it is cardiovascularly safe, so it doesn't increase cardiovascular risk. But is it protective? It's not. It is protective, but from my suspicion is through the diabetes control, because the UKPDS follow-up trials, like in the clinical trial itself within that 10 years. There was reduction in microvascular complications, not macrovascular complications. But then when they followed these patients after 10 years, 20 years, 30 years, the macrovascular complications, the heart attack, strokes rate was much lower in those who took the intensive therapy with insulin or with metformin, also resulted in reduction in those macrovascular complications. But the benefit did not appear immediately within the clinical trial window of 10 years, not like liraglutide, for example, or like a semaglutide oral within 2 years, like we got like a cardiovascular benefit. So it is cardiovascularly safe, it is a neutral, and the benefit from a cardiovascular point of view is sustained over years through the glycemic benefit. This is my suspicion. I don't know if any of what's your opinion and other colleagues' opinion on this?
Tariq or Dr. Farouqi, Huda?
Yeah, sure. I concur with you, Dr. Ali. It's through the glucose, but it's nothing beyond.
Okay, Huda, you told me these are very appealing and very good drug, right? So here a question about the use of tirzepatide in a dose of 15 milligram. If you have a pen of 15 milligram and you want to save money on this, so you want to take 2.5 milligram weekly. So is that possible, or is it a good way of doing this?
Okay, if you look at it from scientific point of view and looking at the pharmacodynamics of the pen, and if you wanted to, the injection, I mean, the fluid that you will inject with the big in pharmacy, if I take the 15 milligram pen, which has the same volume as the 2.5 pen, which is the 3 mils, more or less. And either I inject the full of the, like, it's about 0.6 ml dose of the 2.5, or I can use the extremely small volume from the 15 milligram to deliver the 2.5. So the volume of distribution will be different in both. How much the body will be absorbing and distributing in the tissues, this hasn't been studied. And I'm sure that the Novo or Lilly did not study that. But from practical point of view, we've been seeing patients using it, calling it microdosing, divisions, because of the cost, and it is still working. Now, this is hasn't been studied, but then practically people are using it. I can tell you from my own practice, IR medicine is completely new and you are GLP-1 naive. Take the first month, the standard classical dose with the full 2.5, at least to test the medicine fully and classically on the body. And if you feel that it is benefiting you, and maybe we can consider if you want to do those microdosing, or at least the next dose, which is the 5 milligrams, instead of having the 15, maybe you can use 10 milligram pen to deliver half of it. Again, because of the concept of volume of distribution. Once we get into the 7.5, maybe I can provide the patient with the 15 milligram, again, for the same purpose, to have a good volume to be distributed in the blood. But it hasn't been studied. This is just, we're becoming creative, Dr. Fathia, with this.
I see.
This is
but
off-label,
I think we've been teaching the patient, we've been teaching the patient to do the clicking method, so that's an off-label of doing it. There is I need to take the last question before we just go to the closing slide. It looked like our colleague here had asked this question 3 times, and forgive me because maybe I overlooked this. So if the patient is on a long having a long-standing diabetes with a high postprandial, can he or she benefit from GLP instead of basal boluses? Dr. Ali, maybe you can take this question.
Yes, certainly. So again, patients, this is dependent on the phenotype and the clinical situation. But in those cases, if the patient has long-standing diabetes and they are having postprandial glucose increase, giving GLP-1 will enhance their insulin sensitivity, will reduce insulin resistance significantly, and will result in enhanced glucose-stimulated insulin secretion. In other words, this glucose that is entering the system after food will result in better insulin outcome overall with the GLP-1 receptor agonist. So to answer that, yes, unless the patient has a low weight. If the patient is having low weight, then if you give them that, they will lose more weight and they may get into other troubles. Also, taking into consideration the other contraindications of GLP-1. Another thing to bear in mind, if they have fatty liver disease, giving GLP-1 will have the upper hand here because it will help reduce that burden on them as well. So the duration of diabetes doesn't have a lot to play with that unless the patient has reached a stage of beta cell failure where insulin is needed.
Thank you very much. And with this, we come to the closure of the session. I would like, first of all, to thank all our excellent faculty, for their all insight about the injectable therapy. And I hope that all the audience had enjoyed as much as I myself enjoyed all the talks. Thank you for all the audience who had remained with us till this time. And I just want to remind you that we just finished the module 5. The module 6 is due to be on diabetes complication from risk to prevention, and it's supposed to be on 18th of August at the same time, 8 p.m. to 10 p.m. UAE time. The webinar will be available on demand, and then also on our learning platform, the EDS Institute, and the EDS also YouTube channel. And also remember to scan the QR code for the post-webinar MCQs in order to, again, obtain your certificate after you attend the last, 6 course. So please scan the QR code here. And with this, I would like to thank you all. And also, again, I thank all our faculty, or our attendants, and also our event organizer, MCI, and all the technical team with us here, Cheryl, Sai, and Jesse, for, being with us here and facilitating all this for us. Thank you very much, and have a great night, and enjoy the rest of the week as well. Thank you.
Thank you very much.
Thank you.
Thank you. Thank you all.
Take
Good
care.
night.
Bye.